Hi guys, this is Alicia with Good Morning Sunshine. We're on week 3 of vet school, day I think 13 today. It was a long day. We were there till 5 o'clock. We had 2 lectures and then we had 2 labs. So I'm very tired and we have labs tomorrow that I haven't even prepared for yet. And it is now almost 8 o'clock at night, I think. Oh, it's past 8, yep. And haven't done notes for tomorrow, barely starting this video, so here we are. It's gonna be another long night. But today we started with the thorax wall and the pleura. So I'm gonna talk about that first, and then I think we got into the thoracic cavity. So yeah, I think so. Anyways, yep. So I know I'm not gonna sound very excited because I am really tired, but we will get through it. So some of our topics are, we had to describe the thoracic wall muscles of breathing, and then we have to describe the structures that bind the thoracic cavity and the muscles of the thoracic wall in breathing. I feel like that was on there twice. I did just read that twice. And then describe the serous membranes and the serous membranes of the body cavities. And then lastly, we have to describe the pleural cavity and the mediastinum. So let's start with the boundaries of the thoracic cage. So the thoracic cage includes the thoracic vertebrae, the ribs, and intercostal muscles, the sternum, and the thoracic outlet. And then we have, of course, the thoracic inlet, which is the T1 vertebrae and the longest colli muscle, the first pair of ribs, the first rib being the shortest and the strongest, and the manubrium of the sternum ventrally. So just to show you the thoracic cage, it's right there. And then we got into the structures passing through the thoracic inlet, which would be the esophagus, the trachea, the externojugular veins, the common carotid artery. He was talking about the carotid cheese, which includes the recurrent lingual nerve and the roots of the phrenic nerve. And then we have the vagosympathetic trunks. And then we got into the boundaries of the thoracic outlet, because of course, if there's an inlet, there has to be an outlet. The outlet includes the last thoracic vertebrae dorsally, the last pair of ribs and costal arch laterally, the xiphoid, and it is closed by the diaphragm itself. So then we got into the intercostal muscles. We have external and internal intercostal muscles. So the external intercostal is used for inspiration, which means breathing in. So the volume increases and the pressure decreases. It fills the ICS up to the CCI. The fibers run caudoventrally, and again, it's used for expiratory. So then the internal intercostal is used for expiration, which means breathing out. So the volume decreases and the pressure increases. So it fills the ICS up to the sternum. The fibers run cranioventrally and it's used for expiratory. Yeah, so both of those actually support the thoracic wall. So we have muscles, example of muscles that are used for inspiration. We have the scalenus muscle, which is inserted into the ribs. We have the serratus dorsalis cranialis muscle. We have the diaphragm, which is the main inspiration muscle. We have the rectus thoracis, which is its origin is the first rib. And then we have the external intercostal muscles, which is ventral to the scalenus. See if I can show you a picture here. So one over here, this is the scalenus, this one. And then 2 up here, we have the serratus dorsalis cranialis. And then 3 is the big diaphragm right here. And then 4 is down here, which is the rectus thoracis. And then 5 down here, of course, we have the external intercostal muscles. So then we also have examples of expiratory muscles, which include the internal intercostal muscles, the serratus dorsalis caudalis muscle. He said this wasn't clinically important. Then we have the transversus thoracis, which is the abdominal muscles which aid also in expiration. They're not shown in this picture, but here are the 2. So we have one down here, which is the internal intercostals, and then we have the serratus dorsalis caudalis up here. And of course, that's the diaphragm again. So then we have the muscles of the thoracic wall, the inspiratory muscles, which I just told you all about, which of course acts to increase the volume within the thoracic cavity. So again, we have the external intercostal muscles, the serratus dorsalis cranialis, the scalenus, the rectus thoracis, and the diaphragm. Those are, again, inspiratory muscles. Their attachments being muscle fibers that are caudal-ventral. Their insertion is on the ribs, is caudal-ventral to their origin. Their main action is to pull the ribs craniodorsally, so craniodorsally, and widen the thoracic cavity. So again, inspiration. So then, of course, I went over the 3 muscles of the thoracic wall, the expiratory muscles, which was the internal intercostal, the serratus dorsalis caudalis, and the transversus thoracis. This is the transversus thoracis is what narrows the thoracic cage. So their attachments are fibers directed cranioventral from the cranial border of the ribs to insert on the caudal border of the preceding ribs. And then their action is to decrease the volume within the thoracic cavity by pulling the ribs caudally, which means this way towards the back. So then we got into the intercostal van being a vein, artery, nerve. So intercostal vein, artery, and nerve. We were talking about where to place the needle. The needle would go in the middle of the intercostal space both ways. So middle this way and middle in between the intercostals. Intercostal nerves are the ventral branches of the thoracic spinal nerves. So then we have intercostal veins, which go to the right unpaired azygous veins, and then the ventral intercostal veins go to the internal thoracic vein. The left side regresses and the right remains. Intercostal being the ICS, if I ever use that term. So the ICS vein run along the caudal border of each rib. So again, you would avoid the caudal side when placing a needle, so you'd always go in the middle each way. because if you have a poor placement, you could either have a hemorrhage or cause major pain to the animal, and we don't want to do that. So then we got into intercostal nerve blocks. So again, you would place, let me see if I can show you, nerve blocks above where you're going to be inserting the needle or cutting. So you would do 2 or 3 adjacent intercostal nerves. They are blocked at the caudal border of each rib by introducing the needle that penetrates the skin, subcutaneous tissue, and muscles, including the intercostal muscles. It controls pain up to 6 hours. So the intercostal nerves are blocked along the proximal caudal border of the ribs, cranial and caudal, to the incision site. So this is what I'm talking about, if it didn't make sense to you. So you would be inserting up here nerve blocks, but the needle or incision is down here. So then we got into the endo-thoracic fascia, which is present in the thoracic cavity. Its clinical significance is that it is continuous with the deep fascia of the neck, so it can go to the thorax, the lungs, etc. through this. So the endothoracic fascia being the connective tissue lining the thoracic wall outside of the parietal pleura. Again, it's continued with the deep fascia of the neck and extends into the thorax. And it forms the CT of the mediastinum, which we'll get into, where it surrounds nerves, vessels, and other structures with the mediastinum. And in the middle mediastinum, it becomes dense. It condenses and forms the fibrous pericardium. So then the diaphragm is attached to the lumbar vertebrae, L2 to L4, and is also attached to the sternum. It is dome-shaped. You should probably know that. It is adjacent to the lungs, the thoracic wall, and the heart cranially, and adjacent to the liver and stomach caudally. It is innervated by the phrenic nerve at C7, 6, and 5. Contraction of the diaphragm increases the volume of the thoracic cavity. Again, it is the main inspiratory muscle. So don't forget, diaphragm, main inspiratory muscle. So here I can show you a little bit. It's a picture of a horse. So 3 here. This white line right here is the caudal border of the triceps brachia. And then 4 here, the pinkish line, we have the cranial surface of the diaphragm. 7. Down here we have the rib. 8, we have the costal arch down here. 9, we have the line of the pleural reflection, which is the yellow line here. 11, we have the 8th costochondral junction at 11, which is these 2 little lines right there. And then 12, we have the olecranon tuberosity. Remember, olecranon being the tip of the elbow, which is here. And then we have the cardiac notch, which is 13, which is right here. There's lots of stuff to remember, huh, guys? Let me see. I have to find what slide I'm on, because I was just using my notes pretty much. Sorry guys, hold on. So we did the diaphragm. or at the diaphragm. So the diaphragm has parts, many parts. It has the tendinous center, which is the central tendon. It is V-shaped. We have the muscle periphery. It has the lumbar part, the costal part, and the sternal part. And then the diaphragm has a few openings. We have the aortic hiatus. We have the esophageal hiatus, and then we have the caval foramen. And I can show you guys all on here. I'm going to show you on this one, actually. So here we have the lumbar parts. Oh god, it moved. Okay. And then we have the caval foramen, that big one right there. We have the esophageal hiatus, which is right here. And then above that we have the aortic hiatus. And then this big thing right here is the central tendon. And then we have the costal part, the sternal part down here, of course. So yeah. Ugh. Yeah. I accidentally touched my screen. Okay. So then we got in the diaphragmatic cupula. It is the most cranial portion of the diaphragm. It includes the trachea, the bronchus to right cranial lung lobe. We have the right auricle, the right ventricle, the left atrium, the cranial vena cava, the caudal vena cava, the aorta, and the capula of the diaphragm. The capula of the diaphragm being that yellow 10 right there, that's where it's located on X-ray. So then we got into traumatic diaphragmatic ruptures in dogs and cats, mainly due to automobile accidents. And it usually involves the costal part, and there's high mortality with that. The liver is commonly herniated organ due to its position and attachment to the diaphragm. Then we got into histal hernia at the esophageal hiatus. It permits the stomach to prolapse into the thoracic cavity, and it may be congenital or acquired. In serious cases, this condition results in gastroesophageal reflux. So we have a left lateral radiograph of the thorax of a dog with the hiatal hernia. So that's what it would look like. I can show you a little bit more. 1 being the trachea, 2 being the carina, and then we have 3 here, which is the lumen of the cardia of the stomach, sliding cranially into the thorax, and then number 4 is the right crust of the diaphragm right here. And then we asked, what is the consequence of losing one of the phrenic nerves? Losing one or both phrenic nerves seem to have minimal effect on the animal's ability to breathe normally. So that's good. The thymoma excision, for example, may result in unintended damage to the left phrenic nerve. When an animal is ambulating, auscultation of the abdominal organs, especially the liver, and the cyclic compression and decompression of the chest wall by the thoracic limb movements aid air circulation to various lung lobes to sustain the animal. In addition, over time, the intercostal muscles, along with other inspiratory muscles such as the scalene, the rectus thoracic, and the serratus dorsal cranialis, tend to hypertroph in order to compensate for the paralyzed diaphragm. However, all in all, just so we got this clear, animals don't need a diaphragm in order to survive. We learned that in lecture. They can survive without it. They just have to compensate for not having it. So then we got into the serous membrane, the pleura and the pleural cavity. The pleura being the cirrhosis lining, the thoracic cavity and the thoracic region. The serous membrane is about 0.5 to 1 millimeter thick, which we talked about the serous membrane in a sitcom before. We learned that I think the first or second week. But anyways, we have a few serous membranes within the body. The pleura being which is in the thorax. We have the pericardium, which is surrounding the heart. I'm sure you've all heard of pericardium. Then we have the peritoneum, which is in the abdominal and pelvic cavities. And then we have the vaginal tunic, which this serous membrane surrounds the testicle and the scrotum. So the body of the serous membranes is the potential spaces between the parietal and the visceral serous membranes. So serous membranes that do that are called pleural, they're called pericardial, peritoneal, and vaginal cavities respectively. There's no viscera within these cavities, only small amounts of serous fluid, which if you remember me talking about, serous membranes always have small serous fluid in them. They do this in order to prevent friction, if you remember correctly. So again, the pleural sac being the balloon, the lung being the blue thing, and we're going to go through each step of what it does. So each serous membrane forms a continuous structure, balloon-like. So then we keep going. And remember, it'll go around. There's always a serous membrane because the serous membrane is continuous, if you remember. So as remember the balloon, I think it was a balloon example actually, putting a fist into a balloon, but it doesn't rupture, it just surrounds. That's basically what this was going through again. And then we got into the regions of the pleura. We have the visceral, the pulmonary pleura, and then we have the parietal pleura, which also has two regions. We have the costal pleura, which lines the ribs and the intercostal muscles, and then we have the diaphragmatic pleura, which covers the diaphragm. And then we have the mediastinal pleura, which covers the mediastinum, which is the space between the lungs. See, remember I told you we'd get to it. Basically the space between the pleural sacs. And then we have the pericardial pleura, which is part of the mediastinal pleura on either side of the pericardium. So the mediastinal pleura, the caudal mediastinal pleura of the left and right pleural sacs fuse together, ventral to the esophagus. They may communicate with each other. It's relatively fragile in the horse, dog, cat, and sheep. But the mediastinal pleura of the ox is more sustainable. So because of the paucity of the connective tissue support to the mediastinal pleura, collapse of one pleural sac in a horse called pneumothorax may lead to the collapse of the contralateral pleural sac also. So then we continued with the mediastinal pleura. The pleura in the ventral part of the dog's and cat's caudal mediastinum are thin and devoid of intervening connective tissue. And this part of the mediastinum is sometimes described as fenestrated. If one lung has collapsed, again, this is called pneumothorax. The other one has a high probability of collapsing as well. Due to the flimsy caudal mediastinal pleura, dogs and cats rarely present with unilateral pneumothorax, so it's always usually both. We have specializations of the pleura. We have the pleural cupullae, one right and one left. They're cup-shaped bubbles of the pleura at the cranial extent of each lung that protrude a short distance through the thoracic inlet into the neck. The pleural cupullae form because the parietal pleura extend further farther cranially than the visceral pleura, the long tissue itself. So I can show you this. It's a picture of the cupullae. If you see this long thing, it's down here. So again, the most cranial part of the pleural sacs is the cupullae pleura. The most caudal part of the pleural sacs is the costodiaphragmate recess. So the clinical importance of the pleural cupula, it projects a little behind the first rib, so they may be injured in penetrating wounds sustained at the base of the neck. So for example, the example we got is if a horse runs into a sharp object such as a fence post and sustains a deep laceration of the chest region, the object may penetrate the cupula pleura, resulting in the pneumothorax, again, and the lung would collapse. However, so then we have the pulmonary ligament, which is the continuation and connection between the pulmonary and the mediastinal pleura at the hilus of the lung. Let's see if I can show you here. I know all these things are really confusing, so it's right there. That's the pulmonary ligament, where that blue, light blue, if you can see it. Another specialization of the pleura is the plica vena cava. It is a separate fold of the mediastinal pleura on the right side that surrounds the caudal vena cava and the right phrenic nerve extending into the diaphragm. So the mediastinal recess is a small pleural space medial to the plica vena cava. It is occupied by the accessory lobe of the lung. So let's get into mediastinum. I know they all kind of sound the same, huh? The mediastinum is the space between the lungs. It contains various structure. It runs from the vertebrae to the sternum in the midline. It is bordered on all sides by the mediastinal pleura. It is continuous with the fascia of the neck cranially. It has three regions. It has the cranial, the middle, and the caudal region. The cranial is from the thoracic inlet to the heart. The caudal region is between the heart and the diaphragm. In the middle is cardiac. So the cranial mediastinum contents, it has a dorsal portion, which includes the esophagus, the trachea, the great vessels of the heart, the brachiocephalic trunk, and cranial vena cava, and their branches. The middle and ventral portion includes the thymus in young, then regress. And then it includes the internal thoracic artery and veins. And also the cranial mediastinal lymph nodes. So then we have the medial mediastinum, which contains the heart. Its contents in the dorsal portion includes the esophagus, the tracheal bifurcation, and the root of the lung. Also the tracheobronchial lymph nodes and the aortic arch. The contents in the middle and the ventral portions of the middle mediastinum include the heart, the pericardium, and the folds of the pleural tissue. So then the caudal mediastinum, which is caudal to the heart, is the smallest compartment. In the dorsal portion, it includes the esophagus, the aorta, and right azygos vein. And then in the middle portion, it includes the caudal vena cava. And in the ventral portion, it is reduced to the potential space between the layers of the pleura. The caudal mediastinal pleura of a horse is fenestrated. A pneumothorax, again, collapsing of the lungs, or air in the pleural cavity on one side can spread to the other side, like I said. It's typically exudative pleural space diseases do not spread due to the plugging of the fenestrations by the exudate. So then we got into the relation of the pleural cavity lung. We have a line of pleura reflection where the costal pleura reflects onto the diaphragm, forming the costodiaphragmatic recess. The caudal border of the lung, it is the caudal most extent the lung expands during aspiration. So to hear lungs, you would go more cranial. Then we have the lines of the pleural reflection. Roughly for all species, it extends from the 8th costal cartilage at the sternum along the curved line to the angle of the last rib. So again, with the line of the pleural reflection, it represents the separation of the thoracic and abdominal cavities. So a needle inserted caudal-dorsal to this line will only enter the abdomen. One place cranial will enter the thorax, and if long enough, the abdomen because of the doming of the diaphragm. So a pink line, it separates the abdomen and thorax. That's the line of pleural reflection. The caudal border of the lung, it parallels the line of the pleural reflection. So then we got in the costodiaphragmatic recess, which is the space where the diaphragmatic and costal pleura are in direct contact without intervening the lung. So you have the lungs here, which are the big orange things, but there's space right here where it doesn't even touch the lung. And that's what I'm talking about. And then thoracentesis, which is a portion of the costodiaphragmatic recess between the line of the pleural reflection and the basal border of the lung, is the location which always devoids the lung. So horses have a spur vein, which is a superficial thoracic vein. And you can see it in horses. This is where tapping happens. And again, the needle is inserted midway between the ribs to avoid injury to the intercostal veins. So then we have pleural effusions, which is the excessive fluid accumulation in the pleural cavity. It limits lung expansion, the lung could collapse, and you could have difficulty breathing. Hydrothorax is the excess serous fluid. Then we have hemiothorax, which is blood, it's trauma, lymphoma, toxins. Then we have pyothorax, which is pus, the thoracic wall wound, a pulmonary infection. Or then we have the chylothorax, which is the ruptured thoracic duct. Then we have the pneumothorax, which means air in the pleural cavity. Like I said, air can enter in two ways: externally, penetrating injury or wound from the outside, which damage the thoracic wall and costal pleura, or internally, due to lung trauma and damage to the pulmonary pleura, a complication with rib fractures, but there is no external wound for the injury to occur. So in the x-ray, it's of pneumothorax. Air has collected within the pleural cavity, making the inside of the thorax appear black as the outside on the x-ray. This is abnormal. Normally, the inside of the thorax would be a grayer shade, representing air contained within the soft tissues of the lung. So I can show you this. So you have normal on the left here. This is normal, but on the right, that's not. That's pneumothorax. Okay, so now that was very long. We have a next set of notes here, which we got into the thoracic cavity. This one's pretty long too. So here we're identifying the contents within the mediastinum. So it's kind of a continuation of what I was talking about. We describe the bronchial tree in different domesticated animals. We have to differentiate between the hilus and the root of the lung. We have to describe the topographical relation of the esophagus and trachea in the thorax. We have to identify the main lymph node structures within the thorax and its clinical importance. We have to describe the course of the thoracic duct. We have to describe the area for lung auscultation and the safe area for thoracentesis. We have to describe the heart anatomical features and understand the blood flow in the system and pulmonary circulations. And then we have to identify the main arterial branches of the thoracic aorta. So let's start with the lungs and the airway and the contents of the thoracic cavity. So we have the two pleural sacs, which is a continuation of what we were talking about. We have the right, which contains the right lung, and then we have the left, which contains the left lung, and then we have the mediastinum, which is centrally located, lying roughly along the midline. So we have the two lungs in orange, and then the midline. So then we have the esophagus, which starts in the neck, is dorsal to the trachea. It has cervical, thoracic, and abdominal parts. The thoracic parts run in the dorsal mediastinum from the thoracic inlet to the esophageal hiatus. The cranial mediastinum is dorsolateral to the trachea on the left side. The caudal mediastinum is ventral to the descending aorta and dorsal to the caudal vena cava. So the thoracic trachea, it begins at the most dorsal visceral structure, entering the thoracic cavity, directly ventral to the longest colli. In the mediastinum, it gradually inclines ventrally from its entrance and attains a position ventral to the esophagus at the level of the aortic arch. In departing from its parallel course with the vertebral column, a space develops between the trachea and the vertebrae that is readily apparent in lateral radiographs. The tracheal bifurcation is where the trachea terminates near the heart base, where it divides into the two principal primary bronchi or bronchi. So again, this is talking about the trachea. So the trachea, I guess I can show you a picture. So trachea, and then it divides into two for the bronchi. So we have respiratory passageway. So it goes from the trachea to the primary principal bronchi, left and right, like I said. Then it goes to the lobar bronchi, one per lung lobe. And then it goes to the segmental bronchi. And then each segmental bronchus serves as one whole bronchiopulmonary segment. And then from here it goes to the segmental bronchi. And then it goes to the true and terminal bronchioles, which lack in cartilage. And then it goes to the alveolar ductules. And then it goes to the alveoli. However, we only need to know that it up to the subsegmental bronchi, he said. So thank God, because that's a lot to know. So then we have a dog bronchial tree, which is what we need to know too. So we need to know the left primary bronchus, the left cranial lobar bronchus, the left caudal lobar bronchus, the right primary bronchus, the right cranial lobar bronchus, the right middle lobar bronchus, the right caudal lobar bronchus, the right accessory lobar bronchus, all located on this tree. That's a lot to know, huh? So then we have the bronchiopulmonary segment, which each lobar bronchus divides into many segmental bronchi. Each segmental bronchus and the tissue it supplies with air is a bronchopulmonary segment. That's what a bronchopulmonary segment is. It is cone-shaped with its apex towards the lobar bronchus and its base under the pleura. So here's kind of an image of it right there. So the tracheal bronchus is what supplies the right cranial lobe. Is present in ruminants and pig. It arises cranial to tracheal bifurcation. The tracheobronchus serves the right cranial lobe, just like I said. The right principal bronchus of the ruminants and pig give rise to the middle, caudal, and accessory lobar bronchi. So then we got into the lungs, which is, of course, oriented horizontally within the thorax. Lungs have an apex, a base, has lobes, and it has interlobar fissures. Lobes of the lung, we have right and left lobe. The right lung has 4 lobes, whereas the left lung has 3. The right lung has the right cranial lobe, the middle lobe, the right caudal lobe, and the accessory lobe. The accessory lobe that lies medial to the caudal lobe, which you can't see in pictures usually, and it surrounds the caudal vena cava and the right phrenic nerve. The left lung has the cranial part, the caudal part, and the lateral caudal lobe. So we have the hilus versus the root of the lung. The hilus being the area, location. He drilled this into our head because people get confused. It is the location where structures go and leave on the medial surface. So where structures enter and leave the lung. Whereas the root is the structures that go and leave. So they wrapped in the pleura that pass into and out of the lung via the hilus. So hilus location, root structures. So then we got into the lung lobe torsion, which is the rotation of the lobe along its long axis with twisting of the bronchus and pulmonary vessels, which equals necrosis. The right middle lobe is the most prone to torsion due to its freedom of movement and deep fissures that separate it from the other lobes. This usually occurs in deep-chested dogs. A lobectomy in dogs and cats can survive with up to 50% lung loss. So the ox has 4 right lung lobes, cranial with cranial caudal parts, has a middle caudal and accessory, and it has 2 left lung lobes. Again, cranial with cranial caudal parts and caudal. But no, in ruminants, both right and left cranial lobes are divided into cranial and caudal parts. The lungs have distinct connective tissue in the lung tissue. In a horse's lungs, you can't see the fissures, but they have 3 right lung lobes and 2 left lung lobes. In the right, they have a cranial caudal and accessory. There's no middle lobe. And in the left, they just have a cranial, which is undivided, and a caudal. In all species, the left lung has 2 lobes, the cranial and caudal. The lateral cranial lobe is further divided into cranial and caudal parts, except for in the horse. The right lung has 4 lobes, the cranial, middle, caudal, and accessory, except in horse, missing the middle lobe. I just caught myself. I'm saying lateral and not left. So the left cranial lobe is further divided into cranial and caudal parts. The cardiac notch is present in all animals. It is the region where the heart is not overlaid by lung tissue. It is a triangular space between the cranial and middle lobes of the right lung, where the borders of these lobes diverge from each other, leaving a significant portion of the pericardial wall uncovered by lung tissue. The apex of the cardiac notch lies on the distal quarter of the 4th rib between the sternum and the CCI. Okay. So then we have aspiration patterns, which occurs when an animal inhales something that isn't air. By gravity, it will go to the cranial and middle lobe of the right lung. Smaller air particles go through the accessory lobe. So, material goes to the right cranial and middle lobes. And then the lighter airborne particles go to the accessory lobe. So auscultation triangle, we have in a horse, cranial, caudal border of the triceps brachii. The dorsal is the apaxial muscles, and caudal ventral is a curved line from the oilcranium to the intercostal space between ribs 16 and 17. So that's your triangle right there on the horse, of where you do, that's your auscultation triangle. Lung auscultation, general for pleural centesis or thoracentesis. So you'd puncture the middle of the intercostals. So in an ox and horse, it'd be at the 7th intercostal space above. So I forgot to show you. But in a horse, you would avoid the spur vein. So then the izygous vein originates in the abdomen, which ends in the thorax. The right versus the izygous vein. It's unpaired. It runs along the right dorsal surface of the aorta, and it drains into the cranial vena cava. And then the left versus the izygos in ruminants only, and they can have both right and left. So then we got into lymph nodes in the thorax. And what do you mean by a lymph center, which is an LC? It is a lymph node or group of lymph nodes that occur constantly in the same regions of all species and drain in similar regions. So the caudal mediastinal lymph nodes in ruminants, typically a single large elongated cigar-shaped. It lies in the caudal mediastinum between the aorta and the esophagus. If enlarged, it can press on the esophagus, the dorsal vagal trunk, and it can make it difficult to swallow. And for digestion, vagal indigestion and bloat. Then we got into the thoracic lymphocenters in the dog, which is intercostal, 5th or 6th space, cranial mediastinal, tracheobronchial, and sternal. So why locate the sternal lymph node? Why locate the sternal lymph node? Most of the lymph from the peritoneal cavity drains into the sternal lymph node via an afferent lymphatic duct that perforates the diaphragm near the costodiaphragmatic recess and runs along the internal thoracic vessels covered by the transversus thoracis muscle. The sternal lymph node may drain the cranial mammary glands. So in some animals, the axillary, which usually drains the thoracic mammary glands, may be bypassed by tumor cells to reach the sternal node directly. And why is T6 interesting for an anatomical landmark? Well, the longest chole muscle arises from T6 vertebrae. The thoracic duct deviates from right to left at T6. On lateral radiographs, the carina shows up as a circular dark spot at T6. The tracheobronchi lymph nodes are located in relation to the carina and can be identified if abnormal radiographs. The thoracic duct is an area draining to the right lymphatic duct, which is 75% of the body. So in addition to lymphatic drainage, the thoracic duct transports fat absorbed from the digestive tract to the venous circulation. Because of this fat, the material within the thoracic duct is known as chyle. The thoracic duct arises from the cisterna chyle between the two diaphragmatic crura and runs cranial along the right dorsal surface of the aorta. T6 passes cranioventrally to the left, running in the groove between the esophagus and left longest chole muscle to open in the area where the left subclavian and external jugular veins join. The thoracic duct may be visible on the left lateral side of the esophagus, cranial to the aortic arch, and should be avoided in surgery. So then we got in the chylothorax. To know if lymph vessels are cut, they remain open for a relatively long period of time due to the lack of clotting factors in the lymph. For example, the chylothorax does not resolve by itself unless medical or surgical intervention is undertaken and the duct is ligated. So then we got into the heart, the location of the heart being in the middle mediastinum, partially left of the median plane. So in a cat it is 25 to 30 degrees of the axis, whereas dogs is 45 degrees from the axis. So here is a dog heart, how it would look on x-ray or just in general. The pericardium is a triple fibrous serous sac, which encloses the heart and the beginnings of the large blood vessels connected to it. It has a fibrous layer and a serous layer. The fibrous pericardium is a condensation of the endothoracic fascia and is tightly adhered to the parietal serous pericardium. It is superficial to the fibrous pericardium is the mediastinal pleura or pericardic pleura. So then we got into the pericardium effusion and pericardiocentesis. We got into the cardiac tamponade, which means the pericardial sac becomes filled with fluid. At increased pressure, the fibrous nature of the parietal pericardium prevents significant expansion of the pericardium, so the heart is compressed, in particular the thinner walled right ventricle. Pericardiocentesis, you insert a needle or catheter from the right side along the 4th or 5th intercostal space between the sternum and the CCJ. It's used for diagnosis or to relieve increased pressure in the cavity. So that's the cardiac tamponade. So grooves of the heart would be the coronary groove, which marks the separation of the atria and ventricle. And then we have the 2 interventricular grooves, which indicate the interventricular septum inside. There's 2, like I said, grooves. You have the periconal and the subsinosal. So the interventricular grooves mark the location of the interventricular septum, 1 interventricular groove on each surface. So we have surfaces of the heart. We have the left side with the auricular surface and then the right side with our atrial surface. We have chambers of the heart. You have the 2 atria, right and left. Each has an ear-shaped part called the auricle. It's part of the base of the heart and receives blood from the great veins. And then we have 2 ventricles, right and left. The left forms the apex of the heart and pump blood to the great arteries. The left atrium lies between the 2 main stem bronchi. Septa in the heart divide the right and left sides. So you have the interatrial septum and the interventricular septum. Valves, we have the semilunar valves, which are between the ventricles and great arteries. And the aortic and pulmonary valves. And then we have the atrioventricular valves, the AV valves, which are between the atria and the ventricles. So here we go. Here's a better picture. So we have the right atrium there, we have the left ventricle there, the right ventricular, but we have the pulmonary valve and the right articulatory valve. We have the aortic valve. Here we have the left atrial ventricle valve, and then the left atrium, right ventricle. I know that's a lot on our picture. So I'm not going to get into blood circulation because he didn't really make it that far. So I'm not going to talk about that, and it's already been 55 minutes, so I know it's a lot of stuff, a lot of confusing stuff. I haven't even learned it yet, so don't worry if you're very confused, because I am very confused. But I hope you guys had a good day today. I did have lab after that, but it was just on muscle groups that I've already talked about in one of my sitcoms, so I wasn't going to go over that, and it's already late. So I hope you guys have a good night, and I will talk to you guys tomorrow.